Kia ora koutou. I've crossed to the other side to primary care, so which is going to be, I think it's quite exciting that hopefully there is going to be more investment in primary care space so that it takes the load off secondary services, but I guess it's a bit of watch this space in the next wee while. A bit about my background. I'm talking to the transition planning guidelines. I was actually involved in the development of these guidelines. A previous job, I worked for the Wherry Centre and was a senior advisor, and so doing a lot of work with the Ministry of Health in those days. And so it's, here we are talking about it again. So I'm going to talk about how we, what our process was with putting this together, and highlight some of the key principles that we felt and we found were useful in transition planning, and provide a case example. But I think in the short time I'm probably only going to get through one. Well, I've only got one, so here we go, and I'm just going to try and not be too unco with this. One of the key things with this transition planning guide, and you'll see it was intended to get some consistent practice across the ICAMs. And for those of you, many of you will know the ICAMs. It's infant, child and adolescent mental health, and at that time we were bringing in acknowledgement of infants in the mix. But it was really to try and get some consistent practice around how we did things. But it was really, the emphasis was on supporting young people transition between services, but in and out of services. And I think the last line there, based on their level of need at that time, I mean, that was the overarching aim. And so this came out of, in 2012, for those of you who also work in the youth space, it was the Prime Minister's Mental Health Project, and there were 22 initiatives that were identified. So for those of us working in youth, we were really excited about all these initiatives and that there would be support for us responding to these initiatives. And we got the core for Initiative 6, which was improving follow-up care of youth discharged from DHB secondary specialist services. So I actually wrote the proposal to the Ministry of Health, and when I was putting it together, there was a lack of empirical evidence around models of transition planning. We had the 1993 discharge planning guide, but that was put out was focused on adults, and it was really inpatient and out to the community. And so I had a look at the work done in the UK, had a look at the work done in Australia, and started to draw pieces together that was a starting point anyway. But we do say the limitations, it didn't have an empirical evidence base. It was really largely drawn on what we identified was working in other countries, or people were trying. But most importantly, what we wanted to do was a consultation with service users, young people. And of course we needed to talk with our own clinicians, and we also needed to talk with GPs. So that was part of our process in going into this. And there were 3 other initiatives, of course. The youth primary mental health space that was being recognised in 2012, trying to improve your responsiveness to youth, and this is when we had the youth one-stop shops, and so services were accessible for young people. And we also, there was quite a lot of emphasis on wait times, because I think back then, it wasn't unusual to have 8-month-long wait times to get into secondary services, and really needed to bring those down to what it is. It's 3 weeks is the ideal these days, and again, trying to get people moving through services more easily. In terms of the context, and these will all be familiar to you, we had Rising to the Challenge, of course, which was emphasising increasing the integration between secondary and primary care. We had the Mental Health Project, Youth Mental Health Project. We had Professor Gluckman's Improving Transitions for Youth, which was about how we recognise the developmental needs of young people up to 24 as well, and how they can move through services. We also had a number of initiatives happening. There was an expectation that there would be better alliance between PHOs and DHBs. 5-6 years on, still a lot of work there to be done, so I guess it's watch this space as time goes on, how we do that in a meaningful way for service users. And there was also, at that time, for those of you working in or have worked in CAMS, we had introduced the choice and partnership approach. And while it was seen as more a demand capacity system, clinical system, the important aspect of that was that it had a value base that we needed if we were going to bring in redesign or transformation to services to manage the capacity demand equation, that we needed to make sure service users remained at the heart of the process so that young people and their families were not neglected. So that was a really strong value base. The other thing is that in any work that we did with young people and their families, that they retain some choice over their journey with us, and then that if they did engage with us, that would be in partnership. So we had these values that were in the context that we developed this plan. So at the Wary Centre, we engaged Joe Chiplin to do all the writing and the hard work of kind of project managing this plan. And there were some key principles that we identified. And again, these are not rocket science. If you're going to bring in change, you need to think about how it is. But the whole point was transition doesn't begin 2 months down the track. It begins the time that the people that we're engaging with the young person coming in. So they've got a clear idea of what lies ahead, what to expect with the service, and they have some sense of, if they engage with us, they've got some control over what they're trying to achieve and working with us. So a structured process that begins at entry, partnership with service users. Now that again seems such an obvious thing to do because the service is all about the service user. But often when we're faced with managing capacity, I drew an iceberg earlier on in my little diagram because often services are just trying to keep afloat, just keeping their heads above water to meet the demand. And sometimes it's about just doing all the things that you're supposed to do, but have you really thought about, have you had that conversation? Are we in partnership with the person that's sitting with you? And it's not that clinicians don't want to do that, it's how do you do that balancing act of time constraints, workload volumes, and keeping the focus on what the young person is saying to you. Family whānau involvement was a particular one for us. It's a STEM, in working in ICAMS, we see young people or children and young people not in isolation of their families, they're part of a wider system. So family inclusiveness was a really important aspect of transition planning. Even with the 16-year-old says, I don't really want mum to be here. But we try and work out, well, who in your family would you like to be part of this, because it's really about finding out and understanding who's going to be best support when you leave our service. So that was really an important principle. Clear, effective and timely communication couldn't be underestimated. That's youth-friendly, youth-relevant and youth-appropriate. Now, I talk about youth, but after we'd done this guideline, we actually thought it's relevant to not just youth, it's relevant to all ages. That importance of making sure that we're engaging in a conversation that is meaningful to the service user. The step care approach to service delivery, and that's something that's still very front of mind for all of us now. I know even moving into my new role, the step care model and how that's working in a primary care space and primary care settings is right front of mind. But back then it was looking at us stepping back and thinking, what is our model of care? What are we offering by being in a specialist service? Which part of a young person's care are we participating in? Because we're we wanted to aim for least intrusive intervention. We come in and we do, when someone's experiencing intense issues, then we up and provide more intense service. And then once those needs are addressed, and it may not be completely, you've eliminated all the symptoms, but you've actually improved either the young person's confidence that they're ready to transition out of your service, or you've done as much as you might need to do. So for a young person, let's say, they come in and their mood's really low and they're immobilised. And then as you work on that, you also connect them with an NGO like Bayes Youth, who does mentoring and support, and suddenly that is actually more relevant to them in terms of where their needs are at, rather than doing some more talking therapy. So again, that was the part of thinking about where you fit in this step care approach. And the shared decision making. Now this one is one that we all hope we do, is collaborative and shared decision making, which is not straightforward because you've got to assume that everyone's on board. And I think I'll come back and talk about that one, because that one is quite a challenge, but you want to make also sure that at least you're doing shared decision making with the service user and whoever are their identified supports. So, co-design. And 5 years ago, we didn't call it co-design, we just said we're going to go out and consult. And so we were very fortunate in the Wherry Centre. We had two very vocal youth advisors, consumer advisors, who were really, really good value to have right there to kind of check things out with. But we also had a national youth consumer network. And these were a group of young people who were working in DHBs who used to come together at regular times, and we'd support them doing that. But it was an opportunity for us to say, look, we're wanting to do this, ideas, and get their thoughts, and really, hear from them what they thought was really important. So these were the things that came up. And I put this one first, really, because this was really a really strong one. Make sure that the transitions don't come as a surprise to us. And for many of the young people, they said, well, and then I get told, well, in 2 weeks' time, we're probably going to discharge you. And, they were saying when you're vulnerable, it takes you a while to get to know someone, you finally feel comfortable, and then you're told it's come to an end. That doesn't work for us. Tell us earlier on. And so, as you see, it said, talk to us early and throughout our time with the service about transitioning, so there are no surprises. So this was really, really important for young people. The second, another one was, it's been a big step to come and seek support. And, having just done some interviews with service users for the Connecting Care project for maternal mental health, it was the same themes emerging. It's a big step to seek support. You're finally there, and the thought of leaving and not coping on your own, where that scaffolding is gone, is pretty daunting. So it was interesting to see that the same themes that we picked up some years ago with young people were actually coming out still with some of the adults. So, and then there's, which those of you who are down the back, it might challenge your visual acuity to actually see that. I'm not going to, just for time's sake, go into all of them, but I think if you get a copy of the document, you'll see them. It's things like, we might not know what other support is out there, help link us in. Knowing when to turn if things go downhill again is also reassuring. These are the same themes that were coming out of talking with our adult service users in doing this project, Connecting Care. So, very relevant. How are we doing for time? Okay. Yep. So in terms of the process of planning, I've highlighted, and we did 3 stages, and when you go back and look at a document that you've been involved in, you thought, oh, could have edited that, or that could have been done. But one of the things that we did is we kept opening each of the key points of what to consider with keep the young person at the heart of the process. And as we just heard, I cannot stress that enough, because with us working with young people, there are many young people who don't feel they can speak up, who don't feel they have that voice, but we've got to find those opportunities to allow that. And that doesn't stop with just developing your process. That's also when you're actually involved in the transition planning. So I think you'll see us, we highlighted that, and it does look like we duplicated things, but it was really to stress that's so vital. The whole thing about it being a structured process. The other thing is agreeing on information sharing. Who can you share information with? For young people, and having things confidential, feeling like they can talk. One of our youth advisors said to young people, actually said, well, it's quite difficult talking when the person that you have the real problems with is in the same room as you, referring to their parents. So I think we have to navigate around some of there's the ideal, but then we have to really consider what's a young person telling us, and how do we, ensure that every step of the way this is a safe process, and a process where they feel that their voice and their view is taken seriously. Agreeing early on the process and on goals and aspirations from transitioning for the service. One of the things that this highlights, as you're planning transition, you also have to make sure all your pathways, you've had a look at all your pathway. Are you doing care plans? Are you doing plans that are meaningful from the get-go? One of the things when we've been reflecting on a pathway that we've had for the adult service we've been looking at, we started to see, that bit, for us to do the next bit, we need to make sure we've done that bit right. So again, it's not, transition planning doesn't stand outside as an adjunct to the care pathway. It's very much integrated into the care pathway, and it may mean that you need to tweak or reset your current pathway, so you're actually getting a better streamlined process that is actually taking account of all those things that we say are good principles. So they're not just principles for transition planning, they're principles for care planning. During the engagement with the service, reviewing the progress regularly, making those times so that a young person, one of the things they fed back to us too was, I'm not sure how I'm going if someone doesn't say, can we just check on your goals? Because I turn up and I talk to this person and I go away again and I'm not sure really, how well I'm doing or not. And that may not be a reflection the clinician hasn't done a good job. It's just the level of communication that the young person needs to feel that they can track their progress. And then transitioning, I'm not keeping up with this, there we go. Transitioning from the service is, it is about that adequate planning and preparation, and seeing that as something that is just part of the, good care pathway, is making sure there's ample time for that transition planning. So not leaving it to the last 2 weeks. And I think the other thing we have to consider is when clinicians move teams, how do we manage handovers? There was another young person who had seen the same key worker, it was for some time, and then they left. And they really felt like the rug had been pulled from under them because they hadn't connected with any other key workers. So, how do we preempt, the unexpected? So a young person or a service user doesn't feel just left in the lurch. And just finally, before I show you the case, I'm probably not going to get time to talk about these in detail, but one of the things is if you're going to implement transition planning, you've got to make sure that the infrastructure to support the implementation is in place. So those are the things that that those of you in quality positions will talk about all the time, but sometimes in the operational services, do we make enough time for reflecting and making sure those processes are in place before we implement a new process like transition planning, like policies and guidelines, systems. The criteria, what constitutes transition? How do we base our decisions on transition? How do we review our processes like the PDSAs, and how do we fit those in? How do we do those audits? The links to primary level services, I think, now I'm in a primary care organisation, still heaps and heaps of work to strengthen that to be done. Electronic information systems too, transition plan. Do I send it to the GP and put it into the inbox? How do you do that? Most of our team weren't familiar with that, but yet there's a lot of work going on for improving electronic transfer of information. And finally, supervision of the team. Supervision, not transition planning and transition, working with your clients in transition is about also integrating that into your therapeutic intervention. It's part of that. So those were the things there. Let's have a look at a case in my few minutes I've got left. Now, one of the things with this guideline, it was intended as just that, a guideline. It wasn't intended as this is policy, this is the process you use. It was to highlight some things to consider when you're developing your own transition planning process. And you may need to make sure it fits for your local setting. So this is an example of a transition plan, but you'll see it doesn't follow exactly the steps, but it was meaningful to the young person. Can you see that down the back without me having to read it? No? You can? Oh, good eyesight. If you just have a read of that, so what happened was the clinician had been talking about transition for some time, but then they put together the plan, and it was a conversation with a young person of what needed to go in it. So they actually did that jointly, of actually working out what the plan might look like. The clinician then took it away to type it up, and then thought there were some other things that needed to go into the plan that they hadn't thought of at the time. But as you see, let me know if I've misinterpreted anything. It's really important that there's always an opportunity for the young person to come back and say, well, no, I didn't mean that, or no, that doesn't work. That's that constant checking in. And so the things that I've been working on, so this young person was a 15-year-old who was in recovery from anorexia. So they had identified that this is what I was like when I came in. So they wanted to put those there because they wanted to mark the change that they'd made. And this is what they felt were sort of the things that were associated with being unwell. And then what got in the way of feeling good. So for them to actually say, this is where I began with, was important. And then the things that I've achieved since I first came here. Now, as you look at this, it hasn't said that they've had family therapy. It hasn't said that they've had mindfulness or that they can use a strategy of self-talk or any of that, because that wasn't relevant for the young person to put in. What was relevant was, I am more talkative now. So even though there were a lot of strategies that young person was taught to be more mindful or be aware of, some of the triggers or some of the things that made them anxious, that wasn't the stuff that they wanted in their plan. So again, the plan has to be meaningful, not to the clinician, but to the young person. And there's the things that have supported my well-being. So things like, as it turned out, the patting the pets was a real good soothing thing. So really, when there was heightened anxiety, just going and sitting and petting one of the pets was a really positive thing for that young person to do easily. And these were the things. So who are my supports? With the family and friends, and the things that supported. Out of all that list of things that they'd tried that worked quite well, it was coming, what are the things that most work? So that was the things that were identified as the things that were really areas, things that this young person had to do and make that a priority. And then finally, my plans for follow-up care. So what the clinician was able to do is have a look. Obviously, it's the GP was the person. This young person did have an identifiable GP. A lot of young people don't. They know that they go to a practice, but they don't know which GP they see. So that's something we had to tease out. The Youth Health Hub is was actually one of my old services, but it was like a one-stop shop type, youth-friendly, so they knew they could go there, and that offered primary mental health packages of care, so they could access that. They also had their school counsellor, who was a go-to person before they came into service, and there was also the school health centre as well. So, again, mapping that out for the young person so they know that, they've got all of these services that I can use, but this is how I can use them. Now, I haven't put the things in here. In fact, in this case, this young person it was decided they didn't have medication continue once they were discharged. But, the plans can add those extra bits. And now there is a bit of a tension here in terms of what's meaningful to the service user and what does clinician GP to GP want? And there's a mixed bag on that. When we just looking at recently, we did chatted to GPs about what they found useful, and there was they really were saying we still need a clinician to clinician letter which has all the technical knowledge, technical information that we need to know to base our medication regime and planning and any alerts that we need to be mindful. They still wanted that, although they were most happy for that to be CC'd to the patient. So there is that tension between a meaningful transition plan for a young person or a service user that's meaningful for them, and also the transfer of that clinical, technical information. And I think that's still something that we have to keep on thinking about how we do that so we're not creating, we still need to do that transfer of care, but how do we do that in a way that's smooth and, seamless? So there's still, that's still a challenge how we do that and how we can do that electronically, how we can do that templated. So if you go into the link that I've left on the website, and you'll see that the Ministry of Health posts these checklists. You can download them. The guides, you may want to do your own checklist, but I would say having checklists, I kind of like checklists, but I'm a clinical psychologist by discipline. We kind of like checklists, so, but checklists are quite useful when you're trying to get the initiative up and running, and there's a transition planning checklist. Those are all on the Ministry of Health website. So, just some acknowledgements too is that that was a case from Marinoto, Child and Adolescent Mental Health. I'd like to acknowledge my old colleagues who will continue to be my colleagues in our integrated primary and secondary care, and Weary, of course, who we put together this guideline that then came out as a Ministry of Health document, but most importantly, the Youth Consumer Network, who were amazing to give us that information and need to continue to be our guide in the work that we do. Kia ora.